Hello and welcome. My name is Jessica Adelman. I'm the Social Media and Communications Manager for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Dr. Natalie Blagowidow presenting on gynecological and obstetric issues in EDS and HSD. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times. However, you are able to type questions into the question box at any time. We will not be able to see or respond to any questions until the Q&A time at the end of Dr. Blagowidows' presentation. Please do not send your question more than once, as it won't increase the chance your question will be answered. It will only make it harder for us to sift through those questions. This webinar is being recorded and will be uploaded to our website and YouTube page within a couple of weeks, barring technical difficulties. Dr. Blagowidow received her MD degree from Cornell University Medical College in New York. Her residency training was in the Department of Obstetrics and Gynecology at the Hospital of the University of Pennsylvania, Philadelphia. Dr. Blagowidow pursued specialty training as a fellow in reproductive genetics and human genetics, Department of Obstetrics and Gynecology, Hospital of University of Pennsylvania, and the Division of Human Genetics at the Children's Hospital of Philadelphia. Dr. Blagowidow is board certified in both clinical genetics and clinical cytogenetics. She is also a founding fellow of the American College of Medical Genetics. Dr. Blagowidows' clinical specialties include assessment of pregnancy by ultrasound, including Doppler flow, and 3D imaging, and by testing, including CVS and amniocentesis. Thank you so much, Dr. Blagowidow, for being here with us today.
Well, thank you so much for inviting me, and we'll plunge right into the talk and look forward to answering some of your questions at the end of the talk. So I will be talking about gynecologic and obstetric issues that arise in association with hypermobile disorders and Ehlers-Danlos syndrome. And in reviewing those, we'll talk about both the gynecologic and OB issues in that order. So gynecologically, the things that will come up with EDS and hypermobile disorders include pain, organ prolapse, and this can extend from the time of puberty and adolescence to the sort of sexually active woman during fertile years, and then even into menopause. Issues can occur at all of those times. And then in terms of pregnancy, we'll talk about symptoms that are a little bit more troubling for people with hypermobile disorders or other forms of EDS, complications that we're concerned about, plans for delivery, what's the best approach, is there a best approach, complications that occur even after delivery, and some guidelines. So, starting with puberty, symptoms of hypermobility and EDS can become worse with puberty, or in a child who's done fine, all of a sudden, once you enter puberty, boom, symptoms arise. And I'll be referring to this Hugon Rodin series a lot because they looked at over, almost 400 women who had hypermobile EDS, and it was a tremendous study that collected a lot of data. What they found was if there was prepubertal symptoms of EDS, things like chronic pain, fatigue, puberty made it worse. And that was in half of those who'd had the prepubertal symptoms, 52%. 17% of the people in their study developed symptoms with puberty. The most common complaint, though, was heavy bleeding disorders. And depending what study you looked at, and I looked at a bunch of different ones, some reported maybe 1/3 of women complained of heavy bleeding, in others 75%. And particularly women with the vascular form of EDS suffered from the most in terms of the heavy bleeding. It's thought to occur in terms of EDS in association with the weakness in the capillaries and perivascular tissue. The platelets and collagen just doesn't interact in a normal way, and the menorrhagia or very heavy periods occur. With the heavy periods, of course, painful periods accompany it. Almost, in three quarters to 90%, that's 73 to 93% of women will complain of painful periods. Now, just like people who don't have connective tissue disorders, there's the dysmenorrhea, the painful periods are due to, I'm sorry, these little pop-ups might happen. Usually it's caused by increased prostaglandin release. It's made in the lining of the uterus, the prostaglandins are, and it causes the muscles of the uterine wall and the blood vessels of the uterus to contract, and that can lead to the pain. How do you treat it? Well, our good old friend, ibuprofen, Advil, Aleve, Postural, all of those anti-prostaglandin, anti-inflammatory drugs will be effective, especially if you start them just as the menstrual period starts. If you happen to be a lucky person and have very regular cycles, if you start the day before, it's even more effective. And can also help with other symptoms, not just painful periods, but the nausea and diarrhea that some women have in association with their menstrual cycles. Not everybody can take the nonsteroidal anti-inflammatory drugs for whatever reason, or find that they don't work that well, or prefer not to take medication. Vitamin B1, also known as thiamine, 100 milligrams a day. Some people find it's effective, and that should be just taken every day, not like when am I going to get my period. You just take it every day, and for some of those women, menstrual cycles are improved. Not proven, but vitamin B6, magnesium supplements. Some people think that it works. It's the kind of thing you can try it, but there hasn't been a good study to prove it. And then acupuncture can be effective as well. And then there's hormonal therapy, and that includes all of these things in these pictures. So to help with bleeding and painful menstrual cycles, we have the birth control pill, progesterone-only medications. I include the IUD as a hormonal treatment because many women will already one mistake. There are IUDs without progesterone in them, but there are some with progesterone, and those are the ones that can also help with painful menstrual cycles. Some of these hormonal medicines will decrease the bleeding as well, and some just work on painful cycles. Usually both work together. And let's turn to our favorite trial, the one that almost 400 women were looked at. And the answer wasn't clear. So this Hugon-Rodin trial found that of people who had symptoms of connective tissue disorders, particularly very heavy menstrual periods or painful periods, 15% who took the birth control pill felt better. That's not great, but some improved. Interestingly enough, the women who took the progesterone-only medication, 25% improved, so it's definitely something to consider taking. People who already found that their symptoms of EDS, whatever those are, that got worse with the menstrual period, so you cruise around, you're doing okay, and then you find, oh gosh, I've got my period this week, and everything hurts more, I feel much more tired. 25% actually, when they took the pill, they were already symptomatic, they got worse taking the birth control pill, but 15% improved. So this is one of those studies that sort of tells you, gee, it helps some people and it actually makes things worse for people. So how do you know which one you are? You have to try the medication, try it for a few months and see how you do. There's really no recommendation that can be made because of the varying results. Now, another problem that a lot of women with hypermobile disorders, including EDS, suffer from is vulvodynia. That is chronic pain or discomfort of the vulva where you really can't find an obvious reason for it. So if there's an infection, that's an obvious reason, you can treat it. If you can't find an obvious reason, it's considered vulvodynia. And unfortunately, again, depending on the study, anywhere between a quarter to 3/4 of women with hypermobile disorders have been found to have vulvodynia, or just prunia, painful intercourse. Oftentimes the two go together. Painful menstrual cycles were always a symptom in these individuals. And so what causes it? Peripheral sensitization of the vulva, or just generally the nerves of the urogenital, pelvic, or central nervous tract are hypersensitive, and this area becomes hypersensitive due to that. In addition to just the pain and sensitivity, some women will also suffer from really impressive swelling either during or after intercourse that can be very painful. And then there's a disorder called persistent genital arousal syndrome, which is sort of self-explanatory, but again can be very disturbing. In terms of treatments, there's many suggested treatments. Obviously, skin care, physical therapy can be effective, psychotherapy, cognitive behavioral therapy, actually Kegel exercises, which are sort of tightening and relaxing muscles in the area, can kind of help mitigate the symptoms, and some medications can be offered for this. Now, as I was reviewing my slides, I said, perhaps, like, here's my little arrow. I don't know that this is an exercise that we want to recommend. I just picture people's shoulders like going out of whack and whatever. So some exercises that are not particularly trying on other parts of the body may be helpful for the vulvodynia. And it's a very challenging issue to deal with. And so I found this chart that said, 120 different treatments you can consider. So one of my favorite, and the way my slides are set up, I have a little area that's blocked, but there's the one that just don't have intercourse. That works really well. Okay, but maybe that's not the solution people are looking for, but surprisingly effective. So these are things to consider. I mean, again, Botox, well, you're kind of numbing everything up, all right, but if you're numb, I don't know. But it's treating the nerve. I could see that would be something to consider. Estrogen is working here, but somewhere else I saw a hormonal, the NuvaRing and Premarin are hormonal treatments. They're not working there. So it's a little all over the place. It ends up being try different things, see what works. And there are specialists who, this is the thing that they like to focus on. And often, at least in major metropolitan areas, you can find people who are interested in treating vulvodynia. But again, it's one of those trial and error treatments quite often. The other GYN issues, endometriosis is seen probably not too different than the general population. Troubling uterine fibroids, 5 to 9%. I actually say that's lower than the general population, but certainly can be troublesome when they occur, can be painful, associated with heavy menstrual cycles. Infertility, there is no difference in the general population in most of the studies that have been published. Now, there was one that said, 48% of women are infertile, but that was, I think, an outlier. So fertility is generally not an issue. And then in terms of menopause, just like puberty sometimes fired things up and made things worse for women, there was an improvement in at least 22% of women once they went through menopause in terms of the EDS symptoms themselves. And then in terms of those who used hormonal replacement therapy, which was close to half of women who were going through menopause, a small percent of them, 15%, found that their hypermobile symptoms were improved. Okay. So that ends the GYN portion. And now we'll pause for, no, we're not going to do questions till the end, but if you have any GYN questions, please send those in, as well as the obstetrical questions. And so what we're going to talk about here are, to start with, the physiologic hormonal changes that can make pregnancy particularly challenging for women with hypermobile EDS disorders. There's an increased level of relaxin hormone. And so what does relaxin hormone do? It relaxes the ligaments, it relaxes connective tissue. So in people who already have relaxed tissue, it really can exacerbate what already exists. So we're talking about joint laxity, then relaxing, leading to more pain in joints. And so in terms of pregnancy, 3 times more likely in pregnancy to seek treatment for pain and instability in the pelvis. Spine and joint pain, low back pain, things you hear about in any pregnant woman, just much more likely to occur with EDS. Doesn't have to, though. But pelvic pain in the sacrum, midline groin pain radiating through the abdomen, and then the pubic symphysis dysfunction. I think I have a slide to show that next. And even the Coccyx Dislocations, that's your tailbone. It's, for those of you who've ever fallen on that, you know how painful that is. But this is just where it happens spontaneously. And when I spoke at the national conference last summer, I said, but this is really pretty rare. And I think 3 people came up and told me, oh no, they had it in their pregnancy. So unfortunately, not rare in EDS and hypermobile disorders. Okay, and then just a little diagram to show, I think really just to break up looking at words on slides, but you can see the pelvis, and again, all of these joints are susceptible to relaxing and becoming painful. Sacroiliac joints, the coccyx, the tailbone here, and then the symphysis pubis, and this over this image shows how this will separate, particularly late in the pregnancy, and that can be excruciatingly painful if it separates and then just separates to the point of kind of rubbing on itself. So not everybody will experience these issues, but it's just something to be aware of. Okay. Other disorders that are common in pregnancy, but more common in hypermobile EDS are GI reflux, and that you treat very much how you would treat everybody. Antacids, start with that, avoiding spicy foods, avoiding opiates because they will slow down your GI tract, and sometimes even sleeping a little bit in a more upright position can be helpful. Varicose veins can worsen in pregnancy, and that you can treat with compression hose. Again, the vulvar issues that we addressed a little bit earlier can be worse with pregnancy, and that would be compression hose that really go up to your waist to treat that. Deep vein thrombosis is another concern, and one study showed that occurs in about 4% of individuals, so particularly those with vascular EDS, but that is something to monitor for, and right away if you're pregnant, let your doctor know if you think you have any issues related to that, and that would be pain, deep pain in the calf, swelling of one leg, not the other leg. Important to to keep an eye out for that and notify your physician. Okay. I think, again, postural orthostatic tachycardia syndrome, POTS, is something some of you may already address in your day-to-day life. With pregnancy, it can intensify. And again, if somebody's not familiar with it, that's where the heart rate increases either 30 beats a minute from the baseline, or just if it's greater than 120 beats per minute when moving from the supine, from laying down to sitting up or standing up position. When that heart rate races, that can create issues for people: dizziness, nausea, palpitations, fainting, fatigue. And so it's thought to occur, pregnancy cardiovascular changes that occur normally in any pregnant woman. Peripheral venous pooling leads to lower diastolic pressure, and because of these pregnancy changes, people who have POTS will find that it can worsen, and some people, again, can develop it just in pregnancy. And the pain of labor, surprise, can make this worse. So painful labors are to be avoided, and we'll talk about that a little bit later. In terms of specifics, Pontwall is one author who had studied 22 women who had POTS pre-existing before pregnancy, and some of whom improved, but 31% worsened. So again, improved, you just never know. Sometimes you're in that lucky category. And some of whom only had symptoms in the first trimester. In the third trimester, it was less of an issue because you tend to retain fluid, and that protects you from developing the symptoms of POTS. But again, in that first trimester, when you're nauseous and maybe not drinking as much, the symptoms may worsen. So it's very important to maintain good salt and fluid intake, especially in that early pregnancy. Have adequate anesthesia so that there isn't significant pain that's going to trigger this. And avoiding Valsalva in the second stage of labor, and that's really bearing down and straining as you're getting to deliver a baby. Now, how do you not bear down and strain and deliver a baby? But this is where, on the flip side of, what is the benefit of having hypermobile EDS? Because the tissues are a little bit more mobile, delivery can actually be a little bit easier, and so hopefully the amount of straining that a woman has to do is, you're not required to just be as forceful in terms of doing the delivery. Miscarriage risk, it's because anything that can go wrong, people like to inflate, but actually the miscarriage risk in most of studies has been close to the population. A few did show a higher miscarriage risk. There's not much you can do with these early losses. There hasn't been a hormonal reason identified. It's just something to keep in mind. And then a few people have reported that there's been an increased risk for loss of twin pregnancies. Premature rupture of membranes, though, is a concern with hypermobile EDS, and we'll have actually the subtypes, if you have a particular form of EDS, what you might want to be more concerned about. But in terms of premature rupture of membranes, that's defined by just rupturing membranes before 37 weeks gestational age, and that's before that gestational age is considered a premature delivery. And what we think happens is that there are altered fibrils in the amniotic, in the amnion, which actually consists of 5 different layers of tissue, but one of the layers mainly consists of type 1 and type 2 collagen, which again, the educated EDS patient is very familiar with the etiology being due to abnormalities there. And so when those are altered, increased risk for premature rupture of membranes. And this is just a diagram that shows all the layers. So again, only one is affected, but it's enough that the risk for rupture of membranes is a little bit higher. And in terms of the studies that are out there, they, again, were a little bit varied and not as specific as I would have liked to identify premature rupture of membranes. But Castori reported on 93 pregnancies, and in 11% there were preterm deliveries, definitely higher than the general population. And so it was thought to be premature rupture of membranes, but it wasn't perfectly documented. Hers showed 25% preterm birth rate. On the other hand, that large study that we've been referring to, 6% preterm delivery rate. So it can vary, but it's something to definitely monitor for. Again, more data. This was, again, the Lynn study was a large study, although the number of patients were only 66, not too bad. But they had 264 pregnancies in that group, and that's 66 with EDS, and then 33% non-EDS patients who had pregnancies affected with EDS. So that's where either the fetus or had EDS due to a new mutation, or where the father had EDS and now the baby had EDS. So they compared where mom was affected or where just the fetus was affected, but mom actually didn't have EDS. So if mom had EDS, premature rupture of membranes 20% of the time. If the baby also had EDS as well as the mom, 35% of the time. But what's interesting, if the mom actually didn't have EDS, but the baby did, and again, the membranes are fetal, they're fetal in origin, they come from the baby, they genetically match the baby, 50% risk for EDS in this LIN study, which again had a decent number of patients. So it again shows the concern for this condition, or this complication in pregnancy rather. And again, particularly in classical EDS, are we concerned? And in this study, they didn't really look at the cervix as leading to rupture of membranes. Incompetent cervix, which we're going to talk about. So the incompetent cervix is, now we're looking at the cervix, and again, we're looking at those fibrils and collagen 1 and 2 fibrils in the cervix that are not normal and maybe cause a weak cervical tissue that can contribute to premature delivery. And so the thought is, because of that abnormal connective tissue, the cervix is incompetent, it opens and allows either rupture of membranes, so which are maybe already weak, to then rupture membranes, amniotic fluid leaks out, and again, higher risk for preterm labor, preterm delivery. And so the recommendation is in any individual who's been diagnosed with hypermobile EDS or any other form of EDS to monitor with vaginal ultrasound every 2 weeks, look at the cervix between 16 and 22 weeks of pregnancy, and then every doctor has their own individual formula, but certainly sort of at that time where you could do a surgical intervention, a cerclage to close the cervix if it's opening prematurely, or other types of treatments are available. And here is an image. This is like we're cutting through the cervix, and this is what we'd like the cervix to look like during most of the pregnancy. This is the baby's head floating away from the cervix, amniotic fluid, and it's this closed cervix. This is the cervical canal, and this looks great. It has a lot of length. The tissue looks nice and strong. Here, the cervix has opened up. It's allowed the membranes to actually drop into the cervical canal out to the outside world. And now here's a pregnancy that's at risk for rupture of membranes, especially these membranes are exposed to bacteria now in the vaginal canal here, or just premature labor. So this is a condition you want to avoid. You want to avoid getting to this point. You want to monitor. If you notice that this is opening partially, that's where you might treat this surgically. All right, so we are moving on to the other thing that happens more often with hypermobile disorders are fetal presentations that aren't your average presentation. So instead of the baby being head down, because especially if the baby has EDS itself, the face, and it's hypermobile, doesn't want to really tuck into a good position, face presentation, brow presentation, breech presentation, or transverse presentation. So all of these things are possible, and it's just something to be aware of. And most of the time, this will mean these days 100% cesarean delivery for these presentations, and sometimes the baby will adjust and be able to deliver vaginally, but oftentimes we're talking C-section. And so exactly, C-section, vaginal delivery, is there one that you should choose right from the get-go? What are the advantages and disadvantages of each? Vaginal delivery, you avoid abdominal surgery, which can certainly have its own complications. However, on the negative side, there's a risk of injury to the perineum. So either if an episiotomy is cut, it could be extended, or the tissue can just tear during the process of delivery. Once the tissue tears, again, the wound healing can be slow, and keloids can form. So on the plus side, avoiding abdominal surgery. On the minus side, having some sort of wound issue anyway. Precipitous labor is something to also remember. As I said, that delivery might be easier, but might be almost too easy. 36% of women will have a very rapid delivery, and so that's something to be aware of and make sure you're not living 3 hours from the hospital. And some studies show that maybe there's an association, increased risk for pelvic prolapse in women who have vaginal deliveries, but not everybody agrees with that. So that's a consideration, but not a strong one. In terms of experience with hypermobility, generally there was less operative intervention in the second stage of labor, meaning it wasn't necessary to get forceps or do a vacuum delivery. That usually that second stage of labor, that pushing stage where, again, we're not doing Valsalva, just gentle pushing, that the advantage of hypermobility and the loose tissue is that that baby will slide through a little bit easier. And actually, for whatever, statistically less likely to have an anal sphincter laceration. That's a 4th degree episiotomy, a large tear. Although tissue can tear, it doesn't usually extend that far. And again, we just said joint laxity, allow for easier passage. And again, this study did not show increased risk for pelvic floor disorders 5 to 10 years after delivery. And that's as far out as they followed people. Risk of hemorrhage is, and I think I have a slide, but we'll do the slide twice, I'm sorry. But anyway, there is a risk of hemorrhage that is higher than the general population. One study had 19%, and the breakdown was during labor, the risk of hemorrhage was 5%, postpartum, reading my own slide with difficulty, during labor 10%, postpartum 5%. That does not add up to 19%. About several percent would be actually even before you get to labor and delivery. And then the treatment for this is DDAVP for uterine atony. So if there's heavy bleeding after delivering the baby to contract the uterus, this is the drug that's recommended. And this is important to think of because it's not what is particularly used for postpartum bleeding in general. Usually the drug that's given is Pitocin, and there are several other typical drugs. But in terms of EDS, this drug for uterine atony is particularly effective and something to keep in mind. Okay. Now, that's the pluses and minuses of vaginal delivery. Cesarean section, well, who likes to be in labor? If you can avoid labor if you have an elective C-section. You can avoid that pelvic floor injury that we just chatted about. However, in the same way, you're avoiding the pelvic floor injury that episiotomy that's slow to heal. Wound healing, it's an abdominal wound that may heal with difficulty, and again may heal with a scar, a keloid that's abnormal and needs additional treatment. So, and that was in one study, again, 46%. So it's a significant concern. It is, of course, as I mentioned before, if the baby's breech or transverse, a C-section is recommended. If there's excessive joint pain where just getting into position to labor and deliver is impossible, C-section, of course. And same thing, preserving the pelvic floor to avoid prolapse of, bladder or vaginal wall or whatever. There really isn't data to say that it's helpful for that. And so the pelvic floor. So for anybody who has hypermobile disorder, EDS, the risk of pelvic prolapse is there, and it's there for everyone, and it's something between 15 and 30%. Because of the weakened pelvic floor, the things that prolapse can be the bladder, a cystocele, the bladder can get distended, and stress urinary incontinence can occur in up to 33% in one study that I looked at. Those pelvic floor exercises I alluded to earlier may be helpful. And again, there are specialists who deal with this, so it can be much more than pelvic floor exercises that you can do. There's a lot of other modalities that they can offer. But the point of avoiding vaginal delivery to avoid developing pelvic prolapse, it's been described in nulliparous women who've never had children, including those who are even teenagers. So just for some people, it's going to happen, and it would not really be a reason to avoid a vaginal delivery. Now, in terms of anesthesia, there are old studies out there that say, ooh, regional anesthesia contraindicated, this can create problems. But more recent studies have shown no, epidural, there's no reason that somebody, unless you've got a horrible scoliosis, and then you just need the best anesthesiologist to take care of you, they can still give you an epidural with scoliosis, but it's, you want somebody who has done more than one or two in their lifetime. But anyway, so regional anesthesia, fine. If local anesthesia is used, now we're back to the vaginal delivery and the episiotomy, you might need a higher dose, and it may take longer to take effect, and that is something to share with the doctors so they are aware of those things and are generous with the local and are patient. Whoops. And now we're getting close to the end of the talk, but I do have a little bit of information about some specific forms of EDS and the complications that particularly tie into those. So I think it's worth, just going through those. So with classical EDS, that is where premature rupture of membranes and cervical incompetence is a particular concern. And again, all of these issues, whether you have classical EDS, you have hypermobile EDS, you can have 4 kids, sail through, no complications, and everything goes fine. I'm talking about the increased risk for these issues to occur, but they, of course, don't necessarily mean that they're going to happen to you. However, with classical EDS, a little more likely they're going to happen. So rupture of membrane, cervical incompetence, malpresentation of the baby, breech presentation. And in some of the studies, they've seen that particularly prone to episiotomy extensions, to that pelvic prolapse, leading to fecal or urinary incontinence, and with problems with treatment. Now, in these smaller studies, they were relating vaginal delivery to the pelvic prolapse. So it's one of those, so if you have classical, should you then really think about a C-section? But wait, the wound healing is difficult. It's a little more difficult decision to make. And there's something called COL-A1. All right, this form of classical EDS, there was one reported patient who did fine and one who had premature rupture of membranes. This is a rare subtype. However, with a little bit more information, there are 2 studies on classical-like EDS due to tenascin X deficiency. So this is C1 EDS. And Egging is one author, and then I'll have the other author's information. So with this particular classical EDS, Egging found in, okay, sorry about this pop-up. Egging found that 5 women, 13 pregnancies, their experience was one had a fetal demise, there was 1 fetal demise in the mix and 10 term deliveries. So in this subtype, they didn't see premature delivery. They did have postpartum hemorrhages, a few precipitous deliveries, and again, the pelvic prolapse. So a little more common with this particular form of EDS. The other author, again, fetal demise twice in the 10 pregnancies in these 4 women, 4 postpartum hemorrhages, so, significant risk, perineal rupture, tear of that episiotomy. And this author actually did have 1 patient who had a premature rupture of membrane. Okay. And then the arthrochalasia EDS, there have been 11 deliveries reported with 4 breech presentations, premature rupture of membranes, 2 that had increased amniotic fluid. So with this subtype, that's easy to monitor for during pregnancy, and decreased fetal movement. Well, was there decreased movement because there was increased amniotic fluid and couldn't perceive the movement as well? Was the baby moving less, swallowing less fluid, which led to increased amniotic fluid? Hard to know which was which. But that was seen with this particular subtype. And the authors also were concerned about perineal tears being an issue. Now with vascular EDS, of course, this is the one form of EDS where pregnancy really can involve some very serious complications. We're talking about the risk of arterial dissection and rupture during pregnancy, labor, or postpartum. And studies have shown that pregnancy-specific complications occurred in 50% of people who have vascular EDS. And what kind of complications? Rupture of the uterus, hemorrhage, and again, before, during, and after, premature rupture of membranes, premature delivery, and severe perineal tears. So it's like everything we've talked about plus the arterial dissection and uterine rupture, and in a significant percent of individuals. And I think Murray had the biggest series in 2014, and that was 35 women, 76 pregnancies. They had, just by the breakdown, 2/3 had a vaginal delivery, 1/3 had C-section, including in that group some emergency C-sections. There were uncomplicated deliveries, 48%, but in the other group, there were those who had preterm deliveries, 22%, 21% had a serious laceration. 4th-degree laceration, that's the anal sphincter, so they did see it in this group, and again, 10 times higher than the population. 11% of individuals had a hemorrhage. Previa, that's the placenta located over the cervix. 4%, just a little higher than the general population risk. Abruption is separation of the placenta from the uterine wall, and that's a very serious emergency. And also an individual intraoperative bladder and venous tear. In vascular events, and these are the things, this is the major concern, 4 lethal vascular events. 1 individual had an iliac rupture after she fell at 33 weeks gestational age. 2 had an aortic rupture in labor, and 1 had an aortic rupture 7 days out from a cesarean delivery. There were also several non-lethal artery dissections, a coronary artery at term, a splenic artery dissection after a vaginal delivery, and then multiple artery dissections that occurred in another individual 7 days after delivery. So again, it's very important to have, with vascular EDS, to have very close monitoring, not only in labor, not only during the pregnancy, but afterwards, especially it seems like that 7 days out time. There were also 2 uterine ruptures, 1 in labor, but 1 during the pregnancy in his series. So the conclusion, however, when they looked at all their data, so that sounds pretty grim, but they found that for women who did not have complications of vascular EDS before they were pregnant, the pregnancy itself did not add to the further risk of death. That was their conclusion. And when they calculated the data on the women who had pregnancies compared to those who didn't, the mean age of death in their population was the same whether people had pregnancies or not. So very serious issues can occur with vascular EDS in pregnancy, but on the other hand, compared to not being pregnant, those very same issues can occur. So it's, again, an individual decision what to do. Okay, and then kyphoscoliotic EDS, due to this lysyl hydrolase 1 deficiency, there was a report on somebody who had decreased fetal movement, premature rupture of membranes, breach, in this case, decreased amniotic fluid. And then several other cases, 3 normal outcomes, 1 very early delivery, 24 weeks, and 3 pregnancy losses. And there was finally a case report of a demise with a maternal death with this particular form of EDS due to a ruptured iliac artery. So limited information, small numbers, but some serious issues. And then the conclusion for these authors were increased risk for these issues, and that specifically the monitoring of aortic root size during pregnancies was recommended. And we're getting to the end. There was one report, oh dear. Yes, I will now learn how to get rid of these pop-ups, which I never figured out with my computer. I apologize for them. Muscular contractural EDS, 1 report, 2 uncomplicated pregnancies, then uterine and bladder prolapse. Would it have happened anyway? I mean, it's 1 person. It's hard to draw a conclusion. And then for vascular EDS, there was a case report of in vitro fertilization where an individual who had multiple arterial aneurysms before even attempting pregnancy was stimulated for in vitro fertilization and had a splenic artery aneurysm during the stimulation. So then what they did was unstimulated cycles, which means just take 1 egg that's usually produced per cycle and try to fertilize that. And they were able to fertilize and have an embryo after numerous cycles, but unfortunately the implantation was unsuccessful. But the plan for this individual was to use a surrogate. And in this particular case, it didn't result in a pregnancy that resulted in a child, but it is something to consider that surrogacy is an option, but if you want to use your own egg, be cautious that just the stimulation cycle can itself be pretty medically challenging to the body. So there are ways you'd have to talk to specialists for reproductive issues, but they may come up with a way to do like a mild stimulation. Collecting 1 egg a cycle is sort of pretty limited, but where you mildly stimulate, you get a few, and you're not really challenging the body as much. Okay. So we mentioned bleeding earlier, so this is sort of a repeat, but just with the emphasis of that classical EDS, vascular EDS associated with the highest rates of bleeding. And we've looked over these numbers already. And just to summarize obstetrical management, evaluating the aortic root preconceptually is great, and depending which form of EDS, monitor it during the pregnancy. Absolutely deliver at a hospital with full services. There is no home delivery going on here. There's no setting up a tub and what. You are in the hospital with anesthesia and a good nursery. Monitoring the cervix, and I think that we want to make that 22 weeks, so I won't fix that slide. Definitely a consultation with anesthesia if there's vascular EDS, POTS, and scoliosis in particular, but I think anybody who wants to chat with them ahead of time, it's not a bad idea. And finally, last slide, management of that vaginal delivery. We talked about the gentle pushing, like of spontaneous pushing rather than directed counting, really intense pushing. Appropriate positioning, avoiding overextending hips. Um, Keep in mind that when you have regional anesthesia, you don't have the feedback. When you have that epidural going, you're all numb. You don't know where your legs are going to be. Are you really injuring yourself? So you might want to practice that position ahead of time. I definitely advocate for doing the regional anesthesia, but to make sure that um, you avoid injury by maybe practicing the position ahead and know what's comfortable. And we had mentioned that DDAVP for hemorrhage, because that acts on the platelets, which, remember, are not functioning in a normal way. And so it's important to make sure they have that drug ready for you. Hopefully you don't need it. And that is it. That is the end of my talk. So I hope that was informative. And then now I'll be ready to answer questions. And this is where I'm new to using this format, so hopefully I will see them, or I will hear them as they come along. But thank you for your attention.
Thank you so much. If you have any questions, please type them into the question box and we'll try to get to as many as we can. The first question is, are you aware of an increased risk of peripartum cardiomyopathy or any other cardiomyopathies in women with EDS?
I am not. Down the hall, just a few feet away from me, is Dr. Francomano. So I will ask her that question, and I know I'm going to submit my slides. So if I'm not able to answer a question like this one, I'm not aware of that, I will certainly add it into the slide and, whether there's any information about that or not, but I'm not aware of it.
Thank you. For people with pain with menses, if they can't use NSAIDs, do you ever recommend intramuscular NSAIDs such as Voltaren?
Uh, I have not personally used Voltaren, but I think it's definitely worth a try. So yeah.
Do you have any recommendations for avoiding ligament injuries during pregnancy, like bracing or physiotherapy?
Yeah, physiotherapy absolutely helpful. I don't know that prophylactic bracing is necessary, but definitely to know your body and just to be. I always say to even people without EDS, but to everybody, princess in pregnancy. This is not the time to challenge your body. You want to just take everything a little bit slower, hold on to that, going up and down the steps, you're holding on to the railing, which you should anytime, anyhow, and just really be judicious about what you're doing. But yeah, prophylactically, I don't think bracing is necessary.
Have you seen an increased incidence of hip dysplasia in EDS during delivery, vaginal deliveries, and do you have any recommendations for that?
I'm sorry, I was just having a Voltaren moment. Sorry, so going back to the last question, then we're going to have you repeat that one. I'm having a moment that Voltaren is somehow related to aspirin, which you're not supposed to take when you're pregnant. I will again look that up and put the answer into the talk. But for now, oh, sorry, but that was a GYN question, so Voltaren is fine. Never mind. Okay. Voltaren, go with it. I will look that one up as well and clarify my answer. Back to the hip. Go ahead. And I'm sorry if you don't mind repeating the question.
No problem. Thank you. Have you noticed an increased incidence of hip dysplasia in women with EDS during vaginal delivery, and do you have any recommendations for that?
So I think maybe that question came in even before the talk, but not particularly. Yeah, hip displacement could occur, especially with the regional anesthesia, not particularly with a normal labor, but just to be cautious about placement and so on. So yeah, things can happen, but not, but with normal preventative maneuvers, those can be avoided. And that's where you may want to practice ahead of time. But yeah, not particular hip dysplasia in terms of actual damage as a result of the pregnancy and delivery now.
Do you know if any of the medication treatments for POTS or dysautonomia are safe for use during pregnancy?
Now I can honestly say I do not. I don't have that information. I can try to check again with Dr. Francomano, see what, say, the top 5 medicines that they use, and add them to a slide and say this is okay, not okay. Most doctors have a good idea of what's safe in pregnancy as they're prescribing, so they will remove them. But yeah, I'd have to look at each drug, to know off the top of my head. And usually we're looking them up just to see if they're safe or not. Some are, but some are not. Usual.
Is there a way to lessen bursted veins during pregnancy?
Outside of, it depends which kind of veins you're talking about. Again, varicose veins, wearing good support hose. And again, there's the kind of, garden variety over the counter stuff. And then there are the better, almost prescribed support garments, or not almost, they are prescribed support garments that are fitted and so on. Of course, they're more expensive. Insurance may or may not pay, but those do a great job of helping. But with small superficial vessels, no, there's nothing specific that's helpful.
Do you have any recommendations for women with EDS who have really delicate skin around the vaginal area that tends to tear really easily with sex or friction, and anything that could possibly be done for that kind of just really fragile tissue?
Yeah, so it's really a challenge. And so if you're talking about actually at the process of delivery, you just want somebody who's hopefully you're not having that precipitous baby flying out kind of delivery, but that's where you want a patient person delivering you. And there are, various sort of soothing lubricants that can be applied, and just kind of try to slowly stretch the tissue as the delivery is getting ready to happen. And that can help. But if you are really fragile, I think some tearing might happen anyway. You can't completely prevent it, but if everything is as controlled as possible, you can reduce the risk of damage or have less damage.
If you are in an area without a doctor who is well versed in EDS, and you're worried about some of these potential complications, do you have any advice for some resources to give to your doctor on either the OB or the GYN side to help your doctor treat you a little bit better?
There are some articles, and maybe I can put a link. I'm just getting a whole little list together, but anyway, a link to them that OBGYNs could look at. People will publish a little review article and say, oh, this is something to look at with your patient. So I can provide a link for that, because, yes, a lot of people aren't familiar with it, and you want to make sure that you don't have to be busy advocating for everything. If they know that these are the things that are routinely recommended, they'll follow that advice. Oftentimes, a consultation with a maternal fetal doctor can also get you kind of the care plan that you would need for your individual pregnancy. Um, so that's something to consider.
Are there any supplements that pregnant women with EDS should consider taking beyond the normal prenatals?
Not that I'm aware of, but you can continue, if you're taking some before you're pregnant, you can continue them, but you just want to make sure to avoid sort of the mega dose of vitamins. Um, you just want to kind of keep it in sort of normal range, normal nutritional range during pregnancy.
Thank you so much, Dr. Blagowidow. That is all the time we have today. We very much appreciate you being here and sharing all this information with us. So thank you so much.
All right, well, thanks so much for inviting me. And I will, those couple of questions that came in, I'll make sure that they're included in the slides, which will be posted as soon as I get them to the FED group. But anyway, I will try to do that in a timely manner. But thank you very much for your attention.
Thank you. As a reminder, this presentation has been recorded and will be posted on our website and YouTube page along with the slides with the extra information. That will happen within about 2 weeks, depending on how long it takes for our editing. Thank you so much for attending and have a great day.